Hello, good morning, good afternoon, good evening, wherever you are. Thank you so much for coming on to another emergency Q&A for families in intensive care and intensive care at home. I want to welcome you to the live stream, and I want to invite you to ask your questions, as many questions as you would like. You can connect with me live here on the StreamYard link that I just posted in the chat pad, or you can post your questions into the chat pad. Now, I'm the host of your show. My name is Patrick Hutzel. I'm the founder of IntensiveCareHotline.com and also managing director of IntensiveCareHotline.com, also the founder and managing director of IntensiveCareHome.com with Intensive Care Hotline. We're providing consulting and advocacy for families in intensive care all around the world with IntensiveCareHome.com. We are sending our critical care nurses into the home 24 hours a day to provide a genuine alternative to a long-term stay in intensive care, predominantly for long-term ventilated and tracheostomy adults and children, but also adults and children on BiPAP, CPAP without tracheostomy, tracheostomy care without ventilation, home TPN, home IV electrolyte, antibiotic infusions, central line, PICC line, Hickman's line, and port management at home, to name a few. With Intensive Care at Home, we are currently operating all around Australia, in all major capital cities, as well as in all regional and rural areas. We're also providing Level 2 and Level 3 NDIS support coordination. Now, what makes me qualified to host a show, Emergency Questions and Answers for Families in ICU and Intensive Care at Home? Once again, my name is Patrick Hutzel. I'm a critical care nurse by background, and I have been working in critical care nursing for over 25 years in 3 different countries. Most of my career I've worked in ICU and intensive care at home, and made intensive care at home a reality here in Australia since 2012. I've also worked in the intensive care at home space in Germany, was part of setting it up there. I also want to welcome our viewers on replay, because I know there's always quite a few viewers that watch this on replay. Want to welcome you too, but it's much better if you come on live for the show so you can ask questions here in real time. Also, if you enjoy the work that I'm doing, if you think it's valuable, subscribe to my YouTube channel, give the video a like, share the video with anyone you think will benefit from getting this information, especially if they have loved ones in intensive care or need intensive care at home services. It's always good to share the video and, send your comments or what you want to see next, so I can create content that is simply user driven. Okay, so now let's get to this week's questions. Let me just have a quick look at my emails that I can read out the question. So one of the questions that we get quite frequently is, how long can someone live on a BiPAP machine? And that needs to be broken down to into 2 segments. One is in intensive care, and one segment is with intensive care at home. So let's look at the segment of, intensive care first in an ICU in a hospital, and is often for short-term use, days or weeks. So often used in hospitals for acute respiratory failure, COPD exacerbations, asthma, pneumonia, but also can be used after cardiac surgery, for example, if people struggle to be extubated, or if people struggle to be extubated after any length of intubation. I've seen it being used there in intensive care afterwards as well. If the cause is reversible, the BiPAP should be discontinued once breathing is improved, and that's again in an acute intensive care environment. But to answer the question more succinctly, someone can live on a BiPAP machine for months or even years, depending on the underlying medical condition, overall health, and whether the BiPAP is being used continuously or just intermittently, like during sleep for sleep apnea. Now, I can tell you that with intensive care at home, we're having multiple clients at home on BiPAP either continuously or intermittently, right? That is often for conditions such as cerebral palsy, Rett syndrome, spinal injury situations, high spinal injury, but also lower spinal injury, where the respiratory muscles or the diaphragm are impacted. Also motor neuron disease, ALS, obesity, hypoventilation syndrome, advanced COPD, advanced asthma. Some patients use BiPAP only at night. Some people use BiPAP intermittently day and night, and some use it 24/7. But some of our clients have been living with BiPAP for many years now, and they need the critical care nurse 24 hours a day, because how can clients with a disability initiate their own BiPAP, if they don't have the awareness of it, So what is it that needs to be considered? BiPAP, generally speaking, is a non-invasive ventilation mode. So what that means is it's usually delivered with a face mask, with a nasal mask, However, but if respiratory failure is progressive, tracheostomy, or in the initial stage, intubation and then tracheostomy and invasive ventilation may be needed. And once again, we also have got clients at home, or had clients at home over the years, that have a tracheostomy and are on BiPAP ventilation. What else is important? Regular monitoring of oxygen levels, of course, CO2 or carbon dioxide levels, and comfort of the patient is critical, because a BiPAP mask is not very comfortable to tolerate, and the risk for skin breakdown and pressure sores on the nose, on the cheeks, is a real concern, and needs to be managed carefully, and needs to be managed regularly, and needs to be monitored quite frequently. So some patients use Mifix dressing, Comfeel dressings, Duoderm dressings to prevent the pressure sores in the face, on the nose, on the skin, on the chin to begin with. What's also important to know is that nutrition, infection control, and skincare, once again, especially around the mask, are also important in long-term use. And nutrition in particular is important because, it is quite exhausting being on BiPAP, right? Infection control is obviously important, making sure the circuits are changed regularly, making sure there is water in the humidifier for the BiPAP machine. Skincare, many patients on BiPAP are severely immobile or are completely immobile. Therefore, pressure area care is very important, making sure patients get turned regularly, get their skin checked, get back washes, get their heels checked, so that skin is not breaking down, or that they have also an air mattress, ideally. So I hope that answers the question how long someone can live on a BiPAP machine. If there are any questions to that particular question, please let me know. Type them in the chat pad, or connect with me live on the StreamYard link here, and we can I can discuss it with you here. You can talk to me live. This is your opportunity. So Another question that's come in this week is from a client that asked, my 60-year-old dad has been in ICU for 17 days after ischemic stroke. He's ventilated with a breathing tube. Now the ICU team wants to do a quote-unquote one-way extubation, and he may not be able to protect his airway. What are our options? So first off, let's do some clarifications of some terminology here. What is extubation? Extubation is the removal of the breathing tube, right? And intubation is the insertion of a breathing tube into the mouth, right? Sometimes into the nose as well, but most of the time into the mouth. So extubation, on the other hand, is the removal of the breathing tube, right? Now, the client's making reference here to one-way extubation. What is a one-way extubation? A one-way extubation is an extubation, removal of the breathing tube with the goal not to put it back in. A one-way extubation is often being referred to in the palliative care setting, in palliative care settings, or in end-of-life scenarios where, you know, ICUs suggest to do a one-way extubation with the goal of palliative care and end-of-life care, with the goal of letting a patient pass away. Now, in this situation, the ICU team is not overtly saying that, but after we assess the situation, we think that the client has a very high risk of ending up with an aspiration pneumonia, and with no reintubation planned, that will lead to the client dying. But like in many situations, we don't think that at the time of the conversation with the ICU team, that was before our involvement, that the ICU team has been transparent. You know, they haven't said that, oh, he'll end up with an aspiration pneumonia and then he will die, but that is what is most likely going to happen. Because otherwise they would say, if they wouldn't make reference to a one-way extubation, they would say something along the lines of, well, we'll extubate, and if he can't tolerate extubation, if he's not breathing, we will re-intubate. That would be a normal process. So it's almost like they want to set him up to not breathe, to end up with an aspiration pneumonia and not reintubate, you know, and that would kill the patient. And that is not what the patient wants. That is not what the family wants, right? So what are options? Well, first off, when we looked at the situation in much detail, right, we found that a tracheostomy as an option has never been mentioned, which is once again misleading the family. So what do I always say? The biggest challenge for families in intensive care is that they don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights, and they don't know how to manage doctors and nurses in intensive care. And this is a classical example, once again. The family had no idea that a tracheostomy is an option, right? They have been clearly misled by the intensive care team. And that's why I'm also always saying that intensive care teams don't even tell you half of what's going on. You don't believe me? That's fine. You don't need to believe me, but I see it all the time in our work that we're doing all day, every day, that intensive care teams are not even telling families half of the things that are going on. And families believe everything that intensive care teams say. They don't know what questions to ask. They don't know what counter questions to ask. They don't even know what to look for. They just take everything verbatim, what they are told. Now, this is where our consulting and advocacy is coming in for families in intensive care, because our advice is absolutely life-changing, right? We have saved so many lives for our clients over the years that I stopped counting. Right? I stopped counting how many lives we've saved over the years with our consulting and advocacy, right? Also, in this situation, the family has been told that, you know, oh, it wouldn't be worth re-intubating because their dad wouldn't have any quote-unquote quality of life anyway if he was to survive. Well, it's good to know that this ICU has a crystal ball. You know, I find it hard to believe that anyone can make predictions about future quality of life. You will only find that out if a patient actually gets a chance to live. That's how you find out about quality of life, right? And that's when you can actually determine whether quality of life is as expected and can be and is as expected and also is accepted by the patient and the family. And if the quality of life is acceptable, then it should be full steam ahead with living the best life they can, right? And if quality of life is not as expected, there's plenty of time to talk about end of life. Plenty of time, right? Talking about end of life after 17 days in ICU is very premature. Very premature, right? The one question that I always have is, where's the rush to kill someone? Where is the urgency to kill someone? That's always a good question to ask, don't you think? It's always a good question to ask the intensive care team if you are in a situation where the intensive care team is trying to rush end of life. The first question that I would ask if I was you is, why are you rushing to kill my family member? Good question to ask, don't you think? Where's the urgency to kill my family member? I think that is one of the most important questions to ask if you think you are stuck in a situation like that. So, like I said, the intensive care team has not mentioned anything about a tracheostomy. Obviously, the family now knows all about a tracheostomy. We've educated them about it. And also when it comes to discussions around quality of life, perceived quality of life, I should say, because that's what it is. Quality of life is just a perception. It's not real. It is what a patient or a family perceives as a good quality of life, not what intensive care teams perceive as a good or a bad quality of life. They need to withhold their judgment and need patients and families let them make their own decisions. Because that's what we've done with intensive care at home. We've created a safe environment for our clients and their families to let them live their best lives, right? And not being judged by anyone what they think. So, what's the advantage of a tracheostomy in a situation like that? It simply gives more time for recovery and allows mobilization. It is much easier to mobilize. You can mobilize a patient with a breathing tube as well, but it is more risky, it is more difficult. So it gives more time for recovery. Then you can mobilize a patient. You can actually determine whether a patient can be weaned off the ventilator, whether they can improve with mobilization. Why is mobilization so important? Patient in ICU after 17 days with a breathing tube would be deconditioned. There would be muscle wastage. So muscles have to be rebuilt, including respiratory muscles. And you can only really do that by mobilizing patients and by doing physical therapy, right? And because there's uncertainty about the prognosis and the family wants more time, that is the best option here. Now, another question that inevitably comes up in a situation like that is there also a chance to delay extubation for more time? So what that means is ask for more time to assess whether there's any neurological improvement or respiratory improvement for your dad, or whether he becomes more responsive. Now, the challenge here is that when you look at the literature and the research, a tracheostomy should be done after 10 to 14 days of mechanical ventilation with a breathing tube. Your dad has passed that by around 3 days now. Now, I would say that if your dad has passed spontaneous breathing trials and is rapidly improving to breathe spontaneously 24 hours a day, on the ventilator, then delaying maybe for another couple of days has its merit. But if your dad is still breathing on SIMV or an ACV mode, where he might take some add-on breaths but not triggering every single breath and is failing spontaneous breathing trials, then I think a tracheostomy is the right next step. Now, in this situation, the family has been told that the risk of a ventilator-associated pneumonia is high if the breathing tube stays in. Now, whilst I agree with that, the risk also stays high if he has a tracheostomy, right? He'll still be ventilated. So it is an argument that doesn't count for me because, if someone needs to be ventilated, there's always going to be the risk of ventilator-associated pneumonia. Now, extubating a patient like this and denying him a tracheostomy will inevitably lead to death. So that's like saying, oh, we stop breathing in case the air is contaminated, right? It's not going to happen, right? Breathing is not optional if you want to live. It's a must. So always check arguments. And one thing that I highly recommend you is never let common sense dissuade you from what ICUs are telling you, right? If ICUs are telling you, oh, it's in the quote unquote best interest for your dad to die because if he stays ventilated, he'll end up with a ventilator associated pneumonia. Well, yeah, sure. That's the risk of ventilation. But the benefit of ventilation is he might survive. Now, if he's being extubated and he'll won't be reintubated and he'll end up with an aspiration pneumonia, he'll definitely die. Never ever let common sense dissuade you from making your own judgment. Always trust your gut. ICUs are very good at telling people what they think they should be doing and what they think is in the best interest for you and for your family. You know, that's a decision that you need to make, right? And in a situation like that, obviously what is very important, you need a second opinion, which is what we have done for this family in this situation, right? So, and also what is really important, I can't stress this enough, never rush end-of-life decisions. Always make decisions today that you don't regret in 12 months' time. Right? Let me repeat that because this is so important. Always make decisions today that you don't regret in 12 months' time. Right? Because if you sign off today on letting your loved one die in the heat of the moment without thinking it through very carefully, in 12 months' time you have second thoughts. And why do I know that? Because we have so many families coming to us saying, oh, you know, my loved one passed away 12 months ago, 2 years ago in ICU. I was just blindly following what the intensive care team was telling me. I didn't check whether there were other options. I didn't get any advocacy. I didn't know any better. Can you do a medical record review to see whether my loved one could have been saved? Breaks my heart every single time because help would have been at hand. Right? Don't come to us doing a medical record review wondering if your loved one could have been saved. Save your loved one now. Now's the time to save your loved one. Not a year later with a medical record review. That's stupid, quite frankly. You know, don't make decisions today that you regret in 12 months' time. Always approach it from that angle. So, so that obviously covers the one-way extubation part. Hopefully you can, you know, implement that if you are in a similar situation. Let's move on to the next question that came in. And if you have any questions, type them into the chat pad or connect with me live here on the StreamYard link. The StreamYard link is in the chat pad. You can talk to me directly here. This is your opportunity to talk to me. Okay, let's move on to the next question that came in this week, which I think is also a very important question. Based on ICU standards, is it ethical or acceptable for doctors to withhold care and treatment, i.e. antibiotics, vasopressors, inotropes, to hasten death against the patient or family's wishes? Now, we're getting this question all the time, and this is why I believe our advice is absolutely life-saving. You know, number one, we have turned so many situations around where ICUs wanted to withdraw treatment. You know, the classical situation is someone comes to us, rings us up and says, hey, tomorrow at 3 o'clock, the ICU team wants to withdraw life support on my loved one and they will die. They want to remove ventilation and they will die. They don't want to die. We don't want him to die. What are our options? Well, the good news is you have options, right? That's the good news. The first thing that you need to know is ICUs are very good at pretending they can do whatever they want. They're very good at pretending we decide who lives and who dies. Well, let me ask you this. do you think that end-of-life decision-making is happening in a vacuum? Think about this logically, right? Because that's what ICUs are basically suggesting, that we decide who lives and dies and no one can challenge it. Now, you can be reassured that end-of-life decision-making is not happening in a vacuum, right? And the reason I'm saying that so confidently is because, like I said, we have saved so many lives over the years where we help families in those situations where ICUs say, oh, tomorrow at 3 o'clock we remove life support, come hail, rain or shine, and your loved one is going to die. Well, that's like executing people, right? And like I said to you, always use common sense, always. It's not common sense to tell a patient or a family, oh, by the way, tomorrow at 3 o'clock we'll remove life support and your loved one will die. That's not common sense, right? So use common sense, use your intuition, and don't be intimidated. Because the minute you are intimidated, you will be walked all over. So let's come back to the question in more detail. So based on ICU standards, is it ethical or acceptable for doctors in ICU to withhold care and treatment, i.e. antibiotics, vasopressors, ventilation, to hasten death against the patient's and family's wishes? Well, of course, withholding care and treatment to hasten death against the patient's or family's wishes is neither ethical, acceptable, nor is it legal. And here is why. Patient rights, medical ethics, law enforcement, patient autonomy. Patients or their surrogates, if incapacitated, have the right to make decisions about their care. This includes the right to request life-sustaining treatment, such as antibiotics, vasopressors, inotropes, mechanical ventilation. Next, beneficence and non-maleficence. Doctors are ethically obligated to act in the patient's best interest and avoid causing harm. Withholding treatment to deliberately hasten death, especially against patient or family's wishes of the patient and family, violates these principles ethically, morally, and on a legal level. Which leads me to legal standards. In US, UK, Australia, most European countries, withholding or withdrawing life-sustaining treatment without consent can be considered medical negligence or even homicide, depending on the intent and outcome. Surrogates have legal authority to make healthcare decisions when patients can't, and their decisions must be honored unless a court or an ethics committee intervenes or is trying to intervene. I mean, an ethics committee really is a toothless tiger, right? Should you be going to an ethics committee? No, unless the ethics committee is independent. Most ethics committees are not independent. So what do I mean by that? Most ethics committees in hospitals are a farce because they're hospital employees and they would never go against their employer. And their employer often wants ICU beds emptied, which means they often want, they want people to die so they can empty ICU beds. That leads me to what's the worst case scenario of an ICU? Worst case scenario of an ICU is to look after someone indefinitely with an uncertain outcome. And your dad, or in a situation where, that we had earlier, where the dad might need a tracheostomy, then all of a sudden that patient fits that criteria, looking after someone indefinitely or for long periods of times with an uncertain outcome. But that is not your concern. Your concern is your family member. Right? Next. ICU guidelines and policies emphasize shared decision-making. Treatment can be limited or withdrawn only when there is consensus. That means, everyone agrees that the patient or the family wants end-of-life care too. What boggles me often is that ICUs would like to make those decisions even though some patients are even awake and alert, and they don't even talk to patients and families. Or they don't talk to patients in particular if they're awake and alert. It's very cowardish. Why don't you ask a patient whether they want to live or die? Very good question to ask, don't you think? If there's disagreement, hospitals try to involve an ethics committee, which again, you don't have to agree to. Once again, ethics committees in hospitals, generally speaking, are not independent. They're usually hospital employees, and you won't get an independent decision there. You will get a whole lot of fluff and from people that are obliged to listen to their employer, right? And of course, you need to get a second opinion, which we can help you with here at intensivecarehotline.com. So, if you suspect this is happening, what should you do? Well, first of all, reach out to us. We can give you quick, action steps, and we can help you turn this situation around, because we've turned so many situations around. So, number one, get access to the medical records, which you should be asking for, by the way, on day one. And consider a transfer to another hospital and get that second opinion from us. And consult patient or advocate or legal representative. We are the patient advocate, of course, And like I said, we have turned many of those situations around, right? So always use common sense. Always use your intuition, what's right and what's wrong. If your intuition is telling you something's wrong, probably is. If common sense is telling you something's wrong, it probably is. If the ICU team is telling you tomorrow at 3 o'clock we're going to withdraw life support without your or your family member's consent, it's probably wrong. So, are there any questions in regards to this question? Any questions, any comments? Ask them now. Type them in the chat pad, or connect with me live here on the StreamYard link. Next question. Again, question that we have been answering for one of our clients, who says, is it medical negligence for an ICU that forced my mother to go to an LTAC? Obviously, this is a client in the US, and didn't prevent sepsis and didn't feed my mother in the PEG tube well enough, or turn her enough so that pressure sores were developed on a ventilator with a tracheostomy. So, again, this situation unfortunately points towards medical negligence. Whether it qualifies legally depends on specific facts and documentation. So, first off, let's look at the forced transfer to an LTAC. That's why I keep saying our advice is life-changing. No one can force you or your family member to go to LTAC. Here's why, right? Not only have we consulted with lawyers about that, not only have we actively stopped ICUs from sending patients to LTAC, because that's part of our consulting and advocacy, right? And once again, you can see some case studies on our website at intensivecarehotline.com. You can even see some client interviews on our intensivecarehotline.com podcast. You can see some testimonials on our intensivecarehotline.com podcast section, right? And on our testimonials section, right? So let's just say you are faced with a situation where you are told tomorrow at 3 o'clock, or Friday at 5 o'clock, whatever, your loved one is being sent to an LTAC, right? You need to object. Why do you need to object? If someone is on a ventilator with a tracheostomy, which is ultimately what often sends patients into an LTAC, right? They are ICU, they need ICU level care, and they need to be weaned off the ventilator. Now, most LTACs say on their website that they're the specialists in weaning, ventilation, and tracheostomy. I encourage you strongly to look up family reviews of LTACs to see whether that correlates with what patients are, what families are saying. If an LTAC says on their website they are world-class at weaning patients off ventilation and tracheostomy, have a look whether that correlates with the testimonials from families, with the online reviews families are leaving, for that particular LTAC. That's the first step that I would do, right? Next, ask for the hospital discharge policy. Because forcing a transfer without proper planning, medical justification, without having the policy support, once again, is probably medical negligence. So what do I mean by that? So when you look at hospital policies, you will probably find, for the discharge policy in particular, that patients cannot be transferred to an LTAC without patient or family consent. Now, there are probably some exceptions to the rule. The exception is that a patient can be discharged home if they are medically stable and they have a home to go to. But I can tell you, most discharges to LTAC are usually happening on a ventilator with a tracheostomy. They're definitely medically not stable to go to an LTAC. Also, is this negligence? Absolutely. So if a transfer goes against established medical guidelines or lacked informed consent, forcing a transfer without proper planning, medical justification or consent can be and should be grounds for a complaint. Next, if sepsis was developed in ICU, and given that it is a common and serious complication in ventilated tracheostomy and immobile patients, if there were signs of infection earlier that went untreated or unnoticed that ended up developing into sepsis, again, this would be negligence, and your dad or your family member should not go to an LTAC. Question is, could sepsis be prevented with proper hygiene, turning schedules, wound care? It simply may suggest failure in standard care. Next, inadequate feeding through a PEG tube. Well, that leads to malnutrition or dehydration through improper feeding and hydration through the PEG tube, and that is serious mismanagement. If you think about it, whether it's food or hydration, that's a basic human right. So basically what you're saying is the ICU withheld food and water, which is a basic human right, for your family member. Is this negligence? Well, if staff, doctors, nurses, deliberately withheld food or hydration and didn't monitor intake, right, or become your family member malnourished, that is a deviation from care standards and is definitely nursing and medical negligence. Next, failure to turn and reposition so that pressure sores were developed. Well, not turning patients too hourly can lead to pressure ulcers and infections. This is one of the most basic standards in ICU, and LTAC failing to do this could definitely be considered negligent. And bear in mind, developing a pressure sore really in a hospital is a never event. So what should you do? Once again, get full access to medical records, including doctors' nursing notes, turning schedules, nutrition logs, wound care documentation, and infection tracking. File a complaint, to hospital executives, state medical board, hospital administration, departments of health. Once again, that's where we can help you. We are writing, or we have written, very successful complaint letters, emails to hospital boards, hospital executives, and get a second opinion, which again we can give you by looking at the medical records and point out where the negligence is actually happening. So, what documents do you need? Admission and discharge summaries, daily progress notes, medical and nursing, also turning schedules, hygiene, documentation, vital signs, PEG tube feeding logs, intake output records, fluid balances, wound care records, ventilator, tracheostomy care logs, sepsis diagnosis and treatment notes, incident reports, photos of pressure sores or signs of neglect. Also good if you create a detailed timeline. We always recommend that you keep timelines anyway, making sure it correlates with the notes in a in the medical records. Request an expert review. Once again, this is where we can help you with. We review the medical records because we are medical and nursing experts. Determine if the care fell below the accepted standards, and confirm that the negligence directly caused harm or worsened conditions. And file a lawsuit if you want to. So, I hope that helps you understand, what needs to happen there. Now, I'll be going roughly for another 20 minutes. And we're going roughly for another 20 minutes. If you have any questions in the meantime, type them into the chat pad, or simply connect with me live on the StreamYard link here. Talk to me directly if you click on the link that I posted in the chat pad. So, then there was an email from a subscriber who says, are there any medical tests in ICU that determine any vagus nerve injury from brain swelling? And the question continues. I do apologize. Okay. There are no standard direct tests in ICU specifically for vagus nerve injury due to brain swelling, especially early on. The vagus nerve is very deep, long, and complex, so injury to it is usually inferred from clinical signs, not a simple test. However, indirect signs and tests can suggest vagus nerve dysfunction, including vital signs, of course, changes in heart rate, variability, persistent tachycardia, fast heart rate, bradycardia, slow heart rate, abnormal blood pressure swings, because the vagus nerve controls a lot of autonomic or involuntary functions. Gag reflex, the absence of a gag reflex might hint at vagus or glossopharyngeal ninth cranial nerve injury. Also, swallowing evaluations. Speech therapists sometimes do a bedside swallowing assessment or even a video fluoroscopic swallow study, VFSS, to check if the vagus nerve helps control swallowing and the larynx is compromised. Next. Laryngoscopy. ENT specialists can scope the vocal cords to look for vocal cord paralysis, a sign of vagus nerve injury. Autonomic nervous system testing. Sometimes they can do tilt table tests, deep breathing tests, or ECG-based testing for heart rate variability, but usually later, not so much in the ICU unless specifically requested. Neck pain and stiffness, like you had, can definitely indicate serious neurological irritation. Brain swelling, encephalitis, hypoxia, trauma can increase pressure at the brain stem where the vagus nerve exists. That could partly explain why you had such awful symptoms. So, you're continuing in your email, as it was my communicating an extremely sore and painfully stiff neck after days in ICU that led to the ICU team finally looking for encephalitis and not before. I also had all my identification on myself and my next of kin up to date for the hospital to inform my next of kin of my hospital admission, which they did not. They were only informed from my friend via social media after 4 days, to which my brother contacted the hospital. Yes, I know you sent an email the other day where you asked, is it normal that ICUs do not inform families when their loved ones is in intensive care, and obviously the intensive care patient cannot contact the hospital directly, because they don't know where their loved ones are. Well, the bottom line here is that it is not usual practice. usual practice is that patients, when they're admitted, you're trying to find out who's the next of kin. If you can't find out for whatever reason, you need to contact the police, or the hospital needs to contact the police and find out. That's common sense. Very common sense. Okay, then moving along from there, I also want to read out a testimonial that we had this week. I actually need to look through that. We had another testimonial from a client. Where is it? There it is. Hi, Patrick. I should say hi, Patrick and team, because I have a team working with me. I'm not a one-man band. I greatly appreciate everything Intensive Care Hotline membership has provided to us. The knowledge you and your team have shared has helped immeasurably. I have learned so much and become more empowered through the videos and emails. There were times when I had no one else to help, and I'm so glad this service was there. I only wish I had listened to you and your staff sooner, and maybe things would have not gotten so bad before they finally got better. Luckily, my sister has survived the horrible experiences she went through and made it out of ICU alive, hoping to have her home safely and recovering in a few days. I'm sure this will be a long recovery at home, and I will try to refer to your advice and advocacy as we navigate the next steps. I hope we can come back to your service when we need it in the future. From one of our members, her name is Anjuna. Well, thank you so much, Anjuna. It's been a great pleasure working with you and helping your sister to get out of ICU. But another thing that I want to point out here is Anjuna was very good in following advice. So what I mean by that is, there are families sometimes working with us and they're not following advice, and then they're wondering why they're not getting the outcomes that they were hoping for. You need to be coachable, and you need to be able to follow advice, because that is what really turns the needle. By following advice that we're giving our clients. So thank you, Anjuna, for the testimonial, and we can only hope and pray that your sister is going to improve on her journey, because I know she's been having a rough time, and by us helping Anjuna, asking the right questions, by evaluating medical records, that's how Anjuna got help very quickly and could really also turn things around, because what the ICU team was saying there in the beginning as well is that her sister won't survive. And even if she does survive, she won't have any quote-unquote quality of life, right? And Anjuna knew that something was wrong. She trusted her gut, and she used common sense. She got a second opinion. And here we are, took a few months. Sister was in ICU for 4 months. She's turned the corner. Now, like she said, a long recovery will be ahead. But what would have been the alternative? The alternative would have been her sister would have passed away. And that's very sad that ICUs, don't go the extra mile until you almost force them to. Some ICUs are going the extra mile. Like I always say, there's a lot of good things happening in ICU. But, the people that we are advocating for, that we are dealing with, come to us because they think they're not getting from ICU what they need and what they want. So Let's get to the next question that again came in during the week from one of our clients who says, does lack of turning and pressure area care and lack of wound care contribute significantly to the worsening of level 4 bed sores and overall decline? Absolutely, the lack of regular turning and proper wound care can significantly worsen level 4 bed sores and contribute to a patient's overall decline. Here is how. Number 1, level 4 bed sores are very severe. These are the deepest type of pressure ulcers involving full thickness tissue loss that can extend to muscle, bone, and supporting structures. Without consistent pressure relief, turning every 2 hours, or without air mattresses, the wound can rapidly expand and deepen. Lack of turning causes continuous pressure, cutting off blood supply and leading to more tissue death. Also, poor and below standard wound care promotes infections. Level 4 wounds are highly vulnerable to infections, including cellulitis, osteomyelitis, bone infection, and even sepsis. If dressings aren't changed properly or the wound isn't clean, bacteria can thrive, worsening the ulcer and potentially spreading systemically. Number 3, systemic consequences. Infection and inflammation from untreated or poorly managed bed sores can lead to sepsis, which is life-threatening. Fever, weakness, confusion, or other signs of systemic decline. Increased metabolic demand, further weakening already frail and critically ill patients. Other complications are pain and immobility might worsen, reducing appetite, activity, and motivation, creating a downward spiral in overall health. Untreated bed sores are also associated with longer hospital stays and higher mortality. If someone is experiencing this kind of neglect, it's a serious issue and may require intervention, possibly involving wound care specialists, patient advocates, like we are here at intensivecarehotline.com, or even legal help, depending on the setting. So, let me repeat what I said earlier, because this ties in with this question as well. A pressure sore, even a red mark, is a never event in nursing care, right? And that's how this needs to be treated. So here we are talking about a stage 4 pressure sore, it's stage 1, stage 2, stage 3, stage 4, right? That's how bad this is, And really, when you look at the literature, level 4 bed sores are actually medical emergencies because it involves full thickness tissue loss with exposure of muscle, bone, or tendons. And in an ICU where patients are often immobile and critically ill, turning every 2 hours is not negotiable. It's actually essential to prevent and manage pressure injuries, right? And not turning them allows constant pressure over bony areas, impairing blood flow and causing rapid tissue death, especially in those with poor nutrition or perfusion, right? And then those level 4 ulcers can easily become infected and developing into sepsis, osteomyelitis, or fistulas, also known as tunneling wounds. Wound care and basic pressure area care is a core ICU nursing standard. ICU protocols demand rigorous skin assessments, turning schedules, and wound management. Neglecting these can accelerate decline through infection, pain and stress response, fluid electrolyte imbalance, increased metabolic demands in a fragile patient, and can continue to overall decline, right? And this can often lead, or untreated bed sores can be a major factor in multi-system decline, leading to multi-organ failure, eventually leading to death, unfortunately, right? And this is why I keep saying to each and every one of you, you need help from day one. You can see where this is going if you're not getting help. You find out that things are deteriorating rapidly, right? So, okay, One last question before I wrap this up, unless you have any questions. Calling for the last shot, so to speak, because I'll be wrapping this up in a couple of minutes. One last question. My dad was sent to ICU for dialysis on the dialysis machine to take off fluids. He has congestive heart failure and his heart ejection fraction was at 30%. While at the hospital, they used Bumix and drain his kidneys dry, which led him to be on dialysis. He was on vasopressors, like one bag, and they couldn't wean him off. The vasopressor had to reach to the fourth bag, and the nurse said he was maxed out. I feel like they killed my dad, and he had a low blood pressure, but they said that kept getting low. Sounds like your dad was in severe heart and kidney failure, and the way they managed his fluids and medications may have pushed his body beyond what it could handle. With the congestive heart failure and low ejection fraction 30%, his heart was already struggling to pump blood effectively. Using Bumix to aggressively remove fluids may have dehydrated him too much, which could have worsened his kidney function, caused low blood pressure, hypertension, and this would have made it even harder for his heart to pump blood to his vital organs. When blood pressure drops too low, vasopressors or inotropes like norepinephrine, noradrenaline, epinephrine, dopamine, vasopressin, phenylephrine, milrinone are used to keep circulation going. But if they kept increasing the vasopressors to maximum levels and he still wasn't stabilizing, it likely meant his heart and circulation were failing. At that point, his body may not have been able to recover. Right? But this is another one of those situations why you need help from day one. Right? This is what I said earlier. Families come to us and ask, could my family member have been saved? Right? Too late. Too late. The question you need to ask day one is, can my family member be saved, and what do I need to do to save my family member? That is the question you need to ask. Much better question to ask, of course. So this was the last question that I was going to today. If you need consulting and advocacy for families in intensive care, go to intensivecarehotline.com. Like I said, we have saved many lives with our consulting and advocacy. And you can verify that on our testimonial section. You can verify that on our podcast section where we've done client interviews at intensivecarehotline.com. We also have a membership for families of critically ill patients in intensive care. And you can become a member if you go to intensivecarehotline.com and click on the membership link, or if you go to intensivecaresupport.org directly. In the membership, you have access to me and my team 24 hours a day in the membership area and via email, and we answer all questions intensive care related. I also do one-on-one consulting and advocacy over the phone, Zoom, Skype, WhatsApp, whichever medium works best for you. I talk to you and your families directly. I handhold you through this once-in-a-lifetime situation that you simply cannot afford to get wrong. I also talk to doctors and nurses directly on your behalf, and I ask all the questions that you haven't even considered asking, but must be asked when you have a loved one critically ill in intensive care. And we also do medical record reviews in real time, so that you can get a second opinion in real time. We also do medical record reviews after intensive care if you have unanswered questions, if you need closure, or if you are suspecting medical negligence. Also, if you like these videos, subscribe to my YouTube channel for regular updates for families in intensive care and intensive care at home. Click the like button, click the notification bell, comment below what you want to see next, what questions and insights you have, and share the video with anyone that has a loved one in intensive care or needs intensive care at home. With intensive care at home, go and check out intensivecareathome.com, where we send our critical care nurses into the home 24 hours a day. We're providing a genuine alternative to a long-term stay in intensive care. And we're currently operating all around Australia. I do these YouTube lives every Sunday, 10:30 a.m. Sydney, Melbourne time in Australia, which is currently 8:30 p.m. Eastern Standard Time in the US or North America on a Saturday evening, 5:30 p.m. Pacific time on a Saturday afternoon. And I look forward to seeing you here next time. Thank you so much for your support. Take care for now, and I wish you and your families all the very best. Take care.